evening, everyone, and thank you for joining us and spending part of your evening tonight learning about camber and how it can help your patients in your own practice. We're really excited tonight to spend some time on the topic of dry mouth and caries. Before we get started, though, just a couple housekeeping items to go over. Everyone's muted, so we can't hear any comments or questions verbally. Make sure, if you have questions, type them in the questions box on the right-hand side of the screen. At the end of the presentation, we'll have about 15 minutes or so to go over some questions that have come through, and we'll do our best to get through as many of those as possible. Any that we don't have time for, we'll definitely get to in the coming days and respond to and get answers for you. So with that, I would like to go ahead and introduce Dr. Kim Kutsch, CEO and founder of Oral Biotech and the Carifree system. He's the world's leading authority on ATP as it relates to caries risk assessment. He's been successfully practicing dentistry for the last 35 years and still practices 3 days a week here in Albany, Oregon. He has a huge vision for curing dental caries, and it continues to motivate him in the research he's leading to improve caries diagnosis and treatment. So I know we have a lot to cover tonight, so with that, Dr. Kutsch, take it away.
Hey, thank you, Cody. Thank you so much. And thank you, everybody, for being with us tonight. I really enjoy these webinars together. It always gives me an opportunity to look at the material and share that with people. And so I really appreciate your time and appreciate you being with us. So tonight we're going to talk about dry mouth and dental caries. And I have to tell you, this is a really big topic, and I think it's one that we all deal with every day in our practices. And it's changed. In the 35 years I've been practicing, I've seen tremendous change in the amount of decay, the presentation of the disease, who it's affecting, and the different risk factors I think that we're dealing with today that I just didn't see like 35 or 30 years ago even. So dry mouth is a very big topic. It's a broad topic as well. So we're going to cover just kind of the highlights of it tonight, but I hope going through this it'll kind of give you some direction on how to help manage these patients, and as you're going through your day-to-day practice with them. I think about dry mouth and I break it down into, for a long time I used the term Xerostomia, and then John Featherstone really suggested that I start using the term hyposalivation, and I agree with John. I think it's a better term than Xerostomia. Xerostomia really applies that you have no saliva, and for the most part, patients suffer with a lack of saliva, or they have a reduction in their salivary flow, but it's not very many patients that have no saliva, and so really a term of hyposalivation I think is a term that we as a profession really should start kind of adopting and using more frequently. And when you think about, reduction in saliva, the sources for that are, it's age-related. It's normal for people to have a reduced salivary output as we age. I think the biggest risk factor that we face today, and we're going to talk about this and talk about the treatment, is certainly with medications that patients are taking and the number of medications that American patients, adults, and seniors are taking today. So I think that, that's certainly an important issue for all of us. And then you have your special needs patients, and we're going to talk about some of those tonight. When I look at xerostomia, that's like a little more severe form of hyposalivation then. Really, it's, again, caused primarily by medications. And then you have the patient who's been through head and neck cancer and radiation therapy. And then last but not least, you've got Sjogren syndrome, which is an autoimmune disease. And we'll talk about that tonight a little bit. And I end up treating quite a few Sjogren's patients. I get them referred to me by dentists and, around the state of Oregon as well. I end up treating quite a few patients who've been through or about to go through radiation for head and neck cancer. So I have an opportunity to see quite a few of these people. I've had some experiences with them, so I'm going to share with you, kind of briefly some ideas on how you might approach or think about treating that patient as well. So just looking at, I want to share some science with you guys tonight. So quite a bit of science actually to kind of give you a better feel, at least an updated vision of what's going on, and as we look at dry mouth. This paper was published back in 2011 in JADA, and it was a survey of self-reported dry mouth. And when this first came out, I thought that it was remarkable. Number one, because 7% of the patients in this survey indicated that they had symptoms of dry mouth. And I thought that number was extremely low. Like I didn't know, but it just seemed like this seems out of place in terms of my clinical experience, because I have patients coming in every day telling me that they have dry mouth. Or if I ask them, do you ever feel like you have a dry mouth, they say yes. So being able to identify that on their own seemed to be a pretty low percentage in my mind. What was interesting also in this survey was patients who were 51 years or older were significantly more likely to report having dry mouth than patients that were younger. And probably a couple of reasons, both discussed in the article, but certainly one is just age-related, and the other one is, as we age, we tend to take more medications. So the JADA study reported 7%. We did a multi-site 6 dental practice study looking at caries risk assessment forms, looking at our form in particular, and looking at risk factors and disease indicators, and then also at the ATP bioluminescence score for patients. And we had, at the time I collated all this data, we had 7,328 patient forms taken from these 6 practices. We now have well over 10,000. But one of the primary risk factors in there, of course, is medications, and you'll see that like 55% of the patients in all of these forms indicated they were taking at least 1 prescription medication per day, and of course then that really relates to dry mouth. And in the survey, or in this study of these patients, this data, 27% of our patients self-reported dry mouth on the risk assessment form. So when they filled out that top part of the caries risk assessment form, do you have, or do you have this? We ended up with 27%, which I thought was a lot closer to, kind of my clinical experience, with, what I see in my practice every day. And so I was a little more, I say, confident in that data than in, say, 7%. Now, this paper was just published. In fact, it's just been published. I think it's in April of this year, and in the Journal of Oral Maxillofacial Surgery. And again, the same kind of thing. They looked at self-reported prevalence of xerostomia and its related symptoms on patients being admitted into the hospital for general health examinations. And in this study, and there was about, I think, 800 and some men and 770 some women in this survey. The prevalence of xerostomia self-reported was 60%, and the prevalence of oral malodor 50%, xerostomia 33%, burning mouth 13%, and taste disturbance 12.5%. And I'm not sure clearly why, but men in their 30s and then women in their 60s showed significantly higher prevalence and greater severity of dry mouth and its symptoms. So here we have 3 sets of data. One at 7% self-reported, one at 27%, and then one at 60%. So I would tell you that I'm probably more comfortable in the 27 to 60% as being, I think, more realistic in terms of what we see in our adult patients today in our practices. But I think it's interesting to look at this data and then kind of get a feel for how does that relate to my own individual practice. Why the big fuss about saliva? It's one of the primary risk factors in dental caries, and in fact, it's weighted twice on the Featherstone caries risk assessment form. And so I think that the important thing for us to recognize about saliva, it's a very complex fluid in the body. It has a lot of different materials that are present in the saliva, and it has a lot of functions besides just keeping the oral cavity moist. The pH of the saliva, and it has 2,290 proteins are found in the saliva. And of the proteins that are associated, or biomarkers that are associated with systemic diseases, 40% of those can be found in the saliva. A lot of those can be found in the blood as well, but 40% of them can be found in the saliva. And we know that we have primary defensive enzymes. There are electrolytes in the saliva. We know that saliva is supersaturated with nanoparticles of hydroxyapatite crystals and fluorapatite crystals. And so the saliva is a very, very complex fluid, and it has a lot of functions in the mouth. So you take that kind of out of the equation, and one of its greatest functions is to maintain the balance of the pH in the mouth. And so you take away this huge protective mechanism, or you reduce it, and you skew that equation, and suddenly you have certainly an increased risk for dental caries. So saliva is certainly very important in the mouth, and so that's when patients have a dry mouth, that's why we're dealing with the issues that we're having. We know that there are a lot of salivary enzymes, and primarily defensive antibacteriolytic enzymes that are found in saliva. Beta-defensin 2 basically is a bacteriolytic enzyme that protects us from the pathogens that cause periodontal disease. And in this study, patients that had lower levels of this genomic DFB4 copy number of beta-defensin 2 had a threefold increase in the severity of bone loss and periodontal disease. So, having saliva is very protective, and certainly we have all of those enzymes. We know also that beta-defensin 1 is again a bacteriolytic enzyme which is primarily defensive. And patients in this study, which I've presented before, this was published in 2010, they carried the G20A polymorphism or the gene for this beta-defensin 1, had 5 times the DMFT and DMFS scores of everybody else of the other 2 polymorphisms. So certainly these bacteriolytic enzymes in the saliva play an important role in us being able to maintain the health in the oral cavity. If we talk about dental caries, I really look at dental caries as a prolonged periods of low pH, that are caused by bacteria and result in net mineral loss. And if we look at that pH, we know that hydroxyapatite mineral above a pH of 5.5 is in crystalline form, and below a pH of 5.5 actually then starts to dissociate into ionic form. And so that, we have that window in the mouth of that pH above 5.5 and below 5.5. Some of the things that help drive the pH down certainly is sugar. And it's as the sugar is metabolized by the bacteria producing acid in the mouth, it drives the pH down. So those bacteria play an important role in, again, beginning the digestive process in the mouth as we chew and break down food, but it also lowers the pH at the same time. And then on the other side of that balance there, we have saliva, which has a neutral or alkaline pH. And then we also have specific bacteria in the biofilm which actually raise the pH as well. And so, saliva functions really as the protective or balancing mechanism that keep homeostasis in the mouth. We can measure the salivary flow. I did this for a lot of years. It doesn't seem to be predictive. So if you want to measure salivary flow as to have another data point to maybe, for education or discuss with your patient, certainly I wouldn't tell you not to do that. I would just tell you, based on all of the scientific evidence that I look at it, it's not predictive. And although it is a risk factor, it's not a risk factor that's a standalone kind of thing that you're going to make decisions from. But we know that from stimulated salivary flow, if you have less than 0.7 of a milliliter of saliva per minute, and basically you have them chew on a piece of paraffin wax and spit in a cup and measure that, we'd have them do that for 5 minutes. It's an easy test to run, but it's just, again, like I say, I didn't find a lot of value in that clinically in my own practice. That they're high risk for dental caries, and if they have produced more than a milliliter per minute, that's kind of the normal range, that they would be low risk for dental caries. And I would just, challenge, if you start looking for, how predictive is this data, it's a challenge. We can also measure salivary pH, and in fact, Doug Young down at UOP, they did this for years, and we tried to correlate it and find how predictive that data would be, and it looked like a shotgun blast. Our plotter it looked like a shotgun blast on a wall. There wasn't any linearity to it at all. So we know that resting salivary pH should be about 6.75, and stimulated saliva pH should be somewhere around 7.8 to 8.0. And again, it's just something that isn't predictive. The pH in the saliva change. One of the challenges with that is it changes so much during the day based on when the patient has just eaten, or what they just had to drink, or if they've got a lot of stimulated saliva. Like right now, I have a lot of stimulated saliva because I'm talking. And one of the interesting things when you stop and think about this, the resting salivary pH is 6.75. It's above the dissolution pH of 5.5 of hydroxyapatite, but the dissolution pH of cementum is 6.70. So there's no margin of error. So when we start talking about these senior patients who are on a lot of medications, they're starting to get a dry mouth, there's no margin of error for those patients in terms of their resting saliva. So if you're starting to see those class 5 lesions on those kind of patients, that's an issue. And there have been a lot of studies published on salivary pH trying to correlate it, and this was one of the few papers that I found. This was published, I think, back in 2006. Actually found, looking at all these parameters and data they collect on the saliva, that the difference between the pH of the stimulated saliva and the resting saliva pH correlated positively with the DMFT scores in the patients in the study, but the results were inconclusive. And so, again, I would tell you that it's interesting to look at the salivary pH. It's more important to understand it, just the lack of saliva, how it affects the risk for dental caries in the mouth. But trying to be predictive, use it for predictive value, it just doesn't seem to work. This is a very interesting paper, and I included it. It's just been published again, looking at patients that have a lot of erosive wear on their teeth, and they collected 6 different data points in the saliva. They looked at the consistency of the saliva, resting salivary flow, and the pH, stimulated salivary flow and the pH, and then also the buffering capacity, and they measured it. And then they tried to correlate that to the erosive wear on the teeth, and found that there was just really no correlation from any of the data points or combinations of the data points. And so at this point in time, collecting all that salivary data isn't really predictive for dental caries very well, and it's not strongly predictive for even erosive tooth wear. So at this point in time, that's not recommended. So we can collect a lot of this data, but if the data, if it helps you with your diagnosis or patient education, that's appropriate. But in terms of trying to get it to be predictive, that's always, it has been and still is a challenge when it comes to dental caries. This paper was published last year, and again, this was a survey. They looked at 1,763 adults, and they found that low resting saliva pH below 6.0 in the overall sample, and low salivary, stimulated salivary flow in older adults over the age of 65 were associated with increased dental caries. What I thought was interesting, low buffering capacity was associated with decreased dental caries in children and in adolescents. And what I also found that was kind of counterintuitive, typically when we see thick, sticky, or frothy kind of salivary consistency, in this study it was associated with decreased dental caries in adults, and I don't understand why that was. Typically that's the patient that doesn't have enough saliva. It's very thick, and it's not fluid. They don't have an abundance of the amount of saliva. But anyway, in this study, it certainly was consistent in older adults. Just from the aging process alone, if we reduce the pH of the saliva and we reduce the output of the saliva, we increase our risk for dental caries. So that's part of the aging process. When we talk about medications that our patients are taking, and this was published from the Mayo Clinic Proceedings from July of 2013, in this survey, 70% of Americans take 1 or more medications, prescription medications per day. More than 50% of Americans take 2 or more medications. 20% take 5 or more. And there were 4 billion prescriptions written in the previous year, which amounted to about $320 billion worth of prescription medications. And one of the things that you have to realize, too, is that statistically, about 50% of the prescriptions written never make it to the pharmacy. So prescription medications are a huge issue in terms of their risk for dry mouth. And in this paper that was published in JADA in July 2011, the authors found that medication use and age were highly significant risk factors for patients reporting xerostomia. Again, that was self-reporting. But again, medications and age. In this paper published in 2008 in the compendium, medications can reduce salivary flow, and it's a major complication of xerostomia that it promotes, or it puts you at increased risk for dental caries. So the papers on this kind of go on, and I think it's intuitive to us at this point in time. And certainly the number of patients and the number of medications that we're taking is, I think, alarming to me as a dentist. This was, I thought, a very interesting paper. This was just published as well. And this looked at 152 patients in nursing homes over the age of 75. They were non-smokers, and they had all of their teeth. And what they found was there was a direct correlation from the sedative load. Like, most of these patients in these nursing facilities, they keep sedated, so that behaviorally they're easier to manage. So they kind of keep them in that fuzzy frame of mind. So these patients are all taking sedatives, and the sedative load, the sedative drugs are directly responsible for reduced or hyposalivation, reduced salivary flow, which increase their risk for dental caries. So, it's something I hadn't really thought of, just outright, but I don't typically think of sedatives as being one of the issues here, but certainly in this paper, and this is current, that's a major issue, particularly for people, adult seniors living in a community environment. Then we look at, it's not just, we talk about the aging, that's the typical dry mouth patient, is the person that's, 75 years old taking 15 medications and living in a nursing home. The challenge for us is that's not the only patients that have dry mouths. Certainly asthma is the number 2 disease behind dental caries in our 0 to 5-year-old children. And so asthma, and you start thinking about these epihalers, they dry out the mouth, the antihistamines that these children take to deal with asthma. So certainly asthma would create a situation of hyposalivation in our children, or in anybody that's taking these medications, but particularly even our 0 to 5-year-old children. In this, this was actually a systematic review. There were 18 papers included, 11 that reported, 15 reported, I think, in the permanent dentition, 11 reported in the primary dentition as well. And they found basically from all the data that having asthma and using these medications doubles the risk for dental caries in both the primary and permanent dentition. So that's kind of within, what we would kind of expect maybe if I asked you, how do you think that would have an effect? This paper was published in 2012, and I include it because it has conflicting data. In this study, they looked at children that were only below the age of 6. They were 71 months and younger and had asthma. And they were, compared with controls matched for age, sex, and socioeconomic status. And what they found was that the asthmatics actually had a lower DMFT score than the control group. I can't remember off the top of my head how many children were in the sample size in this study, but, so you have one set of data set of basically if you have asthma in a child, it doubles their DMFT scores, and then here it says that they actually had lower DMFT scores. So I think it's important for us to look at all of our scientific information. It doesn't all agree always, but I think we have to be honest about the evidence base that we have, and continue to look at both positive and negative reporting. So anyway, in this situation, the asthma decreased the DMFT scores. Another condition that's been studied pretty extensively is ADHD in children. And interesting things about ADHD is that they tend to have, they're very similar to control in terms of their caries rate, DMFT scores. Pretty much all the studies come to the same conclusion. They look pretty much identical when it comes to diet, health behaviors, mutant streptococcus lactobacillus counts, the salivary buffering capacity, and the caries rate. Well, what they found was that the children who are have ADHD and that are medicated have hyposalivation compared to control. And certainly having hyposalivation puts them at greater risk, although we didn't see that, haven't seen that as an outcome in some of these studies. So ADHD is potentially a hyposalivation issue. Again, another paper that was just published in the last couple of years on ADHD, and the group had lower unstimulated saliva flow, but there wasn't any difference in the DMFT scores, and wasn't any difference in their diet or their oral health behaviors. So ADHD is going to maybe result in hyposalivation, but we have not seen it result in increases in the dental caries risk. Other things that may have influence on the saliva, I thought this was an interesting paper. This was published 4 years ago in JADA, but the salivary flow rate was the same in long-term alcoholics, but the pH of the both stimulated and unstimulated saliva in the chronic alcoholism group versus controls was lower, which increases their risk for dental caries as well. So there wasn't reduction in the amount of saliva, but it reduced the pH of the saliva. Then we look at smoking, chronic long-term smokers, and I thought this was interesting. This was just published this year. The prevalence in this study of xerostomia in the smokers was 37% versus 13% in the non-smokers. The prevalence of hyposalivation was 43% in the smokers, where it was only 8% in the control group. So we know that long-term smoking certainly creates the fibrotic issues in the gingival tissues. We talk about periodontal disease, but it also reduces the long-term salivary output. I don't know the mechanism, but it's certainly something that's been reported. Then a couple of papers, in fact, one was just published earlier this year looking at adiposity, or the body mass index, obesity and body mass index. And both of the papers that I've read that have been published reported increased hyposalivation, and then also increased risk for dental caries as a result of that, with increased obesity or body mass index in children. Both of these studies were in children. So certainly, as we have obesity issues in the United States, it's not something that I would just again think of. Oh, this child is overweight. Maybe that be causing a hyposalivation issue. That's not something that I think is linear in terms of logic, but it's something I think that we need to be aware of. Then we've got special needs, and certainly we've participated at Carifree in the Special Olympics. We're doing that again. We've done this for four years now, and looked at, we get an opportunity, volunteer groups of dentists get an opportunity to study this group of special needs individuals, because you have all these athletes together at the same time. So, you have a population where you can actually take a look and try to understand, what does dental caries look like in this population? What does the saliva look like? What does their ATP bioluminescence look like? What kind of needs do they have in terms of dental care that, that we need to address and that we haven't really looked at? So special needs is an issue. When you start talking about special needs, and I know that we all treat special needs patients, cerebral palsy, in this study, it looked like the DMFT scores were higher, the salivary pH buffering capacity. They measured all of that in the study. A significant correlation was observed only between the salivary pH and dental caries in the primary dentition of the cerebral palsy children. So, they looked again at salivary flow rates, buffering capacity, et cetera, but the only thing that had any correlation was just between the salivary pH and the dental caries rate of the primary teeth in this group of patients. When we talk about Down syndrome, this was an interesting paper that was published 2 years ago, and the conclusion was that, I treat a number of Down syndrome patients, and I would tell you that, thankfully, they have very low decay rates. The level of dental caries in Down syndrome patients, if you look at them, there's been a large number of studies trying to understand this phenomenon, but they tend to have very low decay rates, and I mean, thankfully so, because, trying to manage a special needs patient in a practice is, creates a whole different set of challenges. So the fact that they have a very low decay rate is a blessing for all of us. But in conclusion, in this study, the lower number of mutant streptococci on the saliva may be one of the factors contributing to the lower caries rate observed in Down syndrome, other than their siblings, despite the evidence of hyposalivation. And I would have to tell you that my own personal experience with Down syndrome patients is that they don't have hyposalivation. In most situations, I see that they have more like hypersalivation. So I thought that was an interesting paper. And I don't know what your personal observations are like, but I always think that it's important for us to read the science and then also kind of compare it. You know, John Kutsch would say, does it pass the smell test? Does it, does this fit with your clinical experience? In this paper, and this was just published again as well, one of the conclusions they came to in the Down syndrome children versus normal children was that they showed significantly lower total antioxidant capacity of the saliva, but they had significantly higher salivary sialic acid levels. And they hypothesized that perhaps that could be explained why the dental caries rate was so much lower in this group of children. The dental caries rate in this study was higher than the controls in the primary teeth, and the permanent teeth it was much lower. And my experience has been that it's been lower in both the primary and permanent dentition in this population of special needs patients. So then we get into head and neck cancers, and I presented, I think, this earlier this year when we did our dental caries update and review, but there's an inverse relationship between head and neck squamous cell carcinoma and dental caries. So people that had dental caries, high levels of dental caries, had less likely to have head and neck squamous cell carcinomas, and patients that were healthy from the standpoint of dental caries were more likely or had an increased risk in those populations of having head and neck squamous cells. So they thought that maybe it was a potential immune response to having the lactic acid bacteria in the mouth that may have protected those patients against head and neck squamous cell carcinoma. But I would say at this point in time, other than it's an interesting observation, I don't think that we know the exact mechanism, or we can answer that. But again, I thought that was interesting, particularly as we talk about head and neck cancers, because that's if you've treated any patients like that, this is perhaps one of the greatest challenges that we have when we start talking about xerostomia. And this paper was just published. This was in the Australian Dental Journal. It was published in March of this year. I would tell you, please go to PubMed, type in these first 2 or 3 authors' names, and do a search. You can read the entire paper is available. Typically, PubMed has the abstracts, but there's a link on the abstract to get the entire article for free. And so this is on the internet, and I would encourage you to go read it. It's one of the best up-to-date papers on how to manage all of the issues for the patient going through head and neck radiation for head and neck cancer, and how that relates to us as dentists and how we're going to try and manage these patients. When I was in dental school 35 years ago, we routinely extracted, it was recommended to extract all their teeth prior to starting the head and neck radiation. And the whole thought process was that they're not going to have any saliva, they're going to end up with a lot of dental caries, we'll have to extract their teeth at some point, and then we have this increased risk for osteoradionecrosis. And so it was better to do the prevention and take all the teeth out. And so that was a routine for a lot of years in the profession. And that is a controversial topic at the moment. It appears that actually it doesn't reduce the risk for osteoradionecrosis by taking the teeth out early. In fact, it may increase the risk for osteoradionecrosis, because as bone heals, it doesn't heal with the same amount of protein and vascularity in the socket as it had when the tooth was there. And so the movement right at the moment is to maintain all of the teeth that you can prior to the head and neck radiation, and then, unless you have teeth that are directly in line with the beam, I read a paper recently that said it might still be a good idea to take those teeth out before anywhere from 10 days to 3 weeks. Ideally, the longer the better, before they start the radiation treatment. But then they're treating the osteoradionecrosis with hyperbaric oxygen at this point in time. But that people that had periodontally involved teeth, actually is recommended to try and save those teeth through the radiation, and then there was a better, or the patients tolerated the procedure much better, had much better outcomes by extracting the teeth down the road rather than taking them out beforehand. So there's a lot of more current science to support keeping all the teeth in the mouth until after the head and neck radiation, and then extracting the ones. Certainly, teeth that are broken, or you have root tips, or you have teeth that are not savable, or they have periapical infections, or what have you. If they're non-restorable, those should be taken out ahead of time, but everything else should be saved, and trying to manage them through the radiation. Of course, then during the radiation, they're going to have an increased risk for candidiasis. They're going to have issues with mucositis. So you've got those issues that you're going to need to try and manage for that patient while they're actively in treatment. Best thing to do as well is is to contact their oncologist, their radiologist directly, and kind of have a multidisciplinary plan of attack so that everybody understands what's going on. Anyway, but this is the best paper that I've read in ages, and I would encourage you to download this, print it out, and read it. If nothing else, print it out and have it in your little library at your desk so that as you see a patient, that you can refer back to this paper or counsel the patient even to read the paper. So anyway, that's an issue. When we get to Sjogren syndrome, this is an autoimmune disease. It tends to be somewhat, mimics rheumatoid arthritis. There's some correlation there, relationship. I don't think we understand that completely yet, but this typically 90% of the Sjogren syndrome patients are women. It affects women 9-to-1 over men, and typically in their 50s. So you're going to see patients with, my typical Sjogren syndrome patient is a woman in her 50s or 60s, and they develop the Sjogren syndrome. The signs and symptoms, they can be tested for it. They can validate, in fact, that they have it, and then, they've got, dramatically decreased output of saliva. These are the xerostomic. These are the patients I would describe as xerostomia or severe hyposalivation. They've got oral burning, the oral, burning mouth syndrome. They have difficult time swallowing, and they have taste disorders. So they've got a lot of other things. They have dry eyes as well. So this becomes a real challenge for these patients. And if not managed well from the outset, it's like a meth addict. If you watch, you can literally watch a meth addict's teeth dissolve. If you're dealing with a xerostomic patient, you can chase dental caries in that mouth and never catch up with them and watch their teeth dissolve as well. And true, same for the head and neck radiation patient. So Sjogren syndrome has those issues associated with it. Certainly, this paper that was just published this year as well, a survey that looked at patients with Sjogren syndrome and their utilization of dental services, and they dramatically had increased utilization for dental caries, periodontal disease, gingivitis, stomatitis. They had all of those issues they have an increased risk and expression of those issues versus a healthy patient. And I think the biggest issues associated with Sjogren syndrome is, they have an increased risk of dental caries. They've got an increased risk of candidiasis, denture sores, frictional oral ulcers, or epilus, and they also have an increase for squamous cell carcinoma. So for your Sjogren's patients, it's something that we really need to keep an eye on and do real thorough oral cancer screening exams annually with them as well. So those are the issues typically to deal with for the Sjogren's patients. So, that kind of gives you a background on the science. A lot of current scientific literature from this year as it relates to these different conditions that are certainly related to dry mouth. Now let's talk about, treatment recommendations, like how do we manage these patients? Well, I like to break treatment down into 3 categories: reparative, therapeutic, and behavioral. And so let's just look at those kind of individually and then look at some of the scientific information around those, and then let's talk about a couple of case histories. Reparative, you still have to do restorations on, any active, cavitated lesions. We certainly have the opportunity to remineralize in these patients as well with fluoride. If we're talking about, therapeutic measures, antimicrobial rinses strategies may be important for the patient that has high biofilm dysfunction. But I would tell you that more often than not, when I look at the patient that has hyposalivation, they typically don't have a biofilm issue. It's really a function of they're just really susceptible. And so they may not have a high bacterial load or a highly active biofilm. So more often than not, I'm not putting these patients on an antimicrobial agent. Obviously, if they do have a high biofilm load, I do, but more often than not, these patients don't. It's just strictly a function of the fact that they're missing that element, that protective element, and it's shifted the balance in their mouth, and they've just become really highly susceptible to the disease, but they don't really have an overload. And again, we talk about fluoride. Xylitol, I think, is really important for a few of these patients. pH considerations are very important. When I mentioned earlier that we know that saliva is supersaturated with hydroxyapatite nanoparticles and fluorapatite nanoparticles, crystallites, for the patient, if the saliva is already supersaturated, do we really need to add some form of calcium phosphate therapy to our mix of ingredients as we're, trying to create some strategies for the patient? Well, for the patient that doesn't have enough saliva in the first place, they don't have enough, calcium and phosphate may be present. And so this is the patient that you really want to use those kind of materials on. Probiotics. Again, I think that's a wild card just yet. I did read, actually, I was reading my Caries Research Journal last night, and I did find a positive report on a probiotic as it, given to the first year of life and affected their decay outcome at age 9. So I think it's a wild card at this point in time. For these patients, I'm more concerned about balancing the pH, keeping them hydrated, and using fluoride and xylitol. When we talk about behavioral, that comes down to diet and home care. Diet, certainly on these patients, you want to make sure that they minimize, acid exposures and stay well hydrated with water. We're going to talk about that. And then, home care, that's an issue that you all know how to address. I don't really think we need to go into that. Critical for the hyposalivation xerostomia patient, John Kutsch, this would be an always in his book, fluoride varnish every 3 months. Fluoride varnish has our best scientific evidence for these patients, and so I would tell you that for any patient that has hyposalivation or xerostomia, fluoride varnish every 3 months. That's the protocol. I would put them on a 5,000 parts per million fluoride gel. Ideally, it would have xylitol in it, and ideally, it would have an alkaline pH. We're trying to supplement or replace the effects of the saliva. So again, that's xylitol. Calcium phosphate, again, I think a form of calcium phosphate is appropriate for the patient that has hyposalivation, and I think that it's critical that the patient stay hydrated and that they drink water, avoid things that dry out the mouth that have alcohol, smoking, smoking and alcohol. Now, that's going to be a challenge, but those are things that we know dry out the mouth as well. This paper was published this last October, and really the whole name of the game here is to help these patients minimize their risk factors. And so if you can sit down and counsel a patient that has, or coach a patient, let's use that language, sit down and coach a patient that has hyposalivation, and you can help them understand where the risk is and how they can maybe modify their behaviors around that, or materials and behaviors around that to help reduce their risk or minimize their risk, that's when they're going to have a better outcome. So it's all about identifying and minimizing those risks. It's the same as dental caries treatment for all patients, but it's even more so. It's kind of like we're even more focused. It's even more important for these patients because without saliva, there is such higher risk. So we know if we look at all the scientific evidence, and here's yet one more paper on the benefit of fluoride varnish, particularly on root surface caries in older adults, and that's the population that we're talking about. So every 3 months, fluoride varnish, just file that, write that down as an always. This study was done in Denmark. There was 6 different nursing homes. They looked at 176 nursing home residents and patients that had root surface lesions, And they found that a 5,000 part per million fluoride toothpaste was significantly more effective at controlling root surface lesions than was just a standard fluoride toothpaste. So again, an always for me on these patients is a 5,000 part per million fluoride gel. You may want to look at if they have a high biofilm load or high bacterial load, high biofilm activity. You may want to look at using an antimicrobial agent. And your options run from chlorhexidine to povidone iodine. And again, I've promoted and recommended sodium hypochlorite here for I think 13 years now. This was a paper that was published in December. And it was actually a periodontal study, but what they looked at was the plaque indices, the amount of plaque biofilm buildup on individual tooth surfaces. And 30 patients that had periodontal disease, 15 in control, and 15 had the sodium hypochlorite rinse. And at the beginning, they did a subgingival irrigation, and it reduced their plaque and biofilm load in their mouth by up to like 400%. So certainly sodium hypochlorite is a safe and effective. Doesn't create any adverse effects or no persistent bacteria. It kills everything, reduces the overall bacterial load, you create the right environment, and the healthy early colonizers come back. That's what they do. And so this gives us an opportunity to hit the reset button, take out all the bacteria, and the healthy ones grow back first. That's how it works. That's how nature works. The early healthy colonizers come back first. And so you're trying to create a healthy environment in the mouth. So sodium hypochlorite there. This was the Bader-Vollmer sugar study that was published in JADA last year that created all the controversy. This was the multi-site study where they looked at the 975 adults and gave them 5 xylitol mints a day and found that it had no effect on their dental caries rate. And that's when all of the anti-xylitol fans came out of the woodwork to point the finger and celebrate and say, see, xylitol doesn't work, we told you so. The problem is when you go then look at the secondary analysis of their data, and this study was published in the Journal of Dental Research then in June, and what they found was that just giving 5 xylitol mints a day to the patients in this population that had root surface lesions, it reduced their decay rate by 40%. So, these are the kind of patients that we're talking about that are xerostomia. A lot of them have root surface lesions because they have gingival resection. They don't have enough saliva. I think that's a real common presentation of this disease in that older patient. Just 5 xylitol mints a day in this study reduced their decay rate by 40%. So I think that we need to always be thinking xylitol when you're creating your strategies. And again, Philip Marsh talks about trying to maintain a neutral pH in the mouth, trying to maintain it around neutrality, create that homeostasis of the microbial balance in the biofilm. So pH is certainly a strategy that we want to talk about. I recommend that these patients drink a lot of water. You want to stay away from anything that's going to dry out the mouth, anything that's acidic. You want to stay away from certainly alcohol, and then just all these acidic drinks. And this came out in January in the AGD Impact. I think it's a great schematic to chat. The problem is they have water over here on the right end of the spectrum at 7.0. That is tap water, and about half of the bottled waters are 7.0 and above. The problem is the rest of the other waters are right here with tomato juice. They're all at 4.0. And so I think that, when you tell patients, most patients today drink bottled water. However, most of our senior patients drink tap water. At least that's my experience in my practice. Something you're going to have to look at in your own practice. But if they're drinking bottled water, make sure they understand that all bottled waters are not the same. This is just one I pulled off of the internet. You can go to Google, do a Google search for pH bottled water. There's 4 or 5 different sites. They come up with by brand name. They come up with the pH of the water. This is really critical for this person. If you go onto the chart here at about Arrowhead water and down, they all have a pH of 7.0 and above. So it's really important for the patient to understand that, I want you to be hydrated, but with a neutral or alkaline water, not a highly acidic water, because we're trying to replace the saliva that's gone. For the patient that has, is going through radiation therapy and the radiation xerostomia, the question becomes, you want to do the restorations beforehand. whatever you're going to do to try and save whatever teeth need to be taken care of. Extractions, certainly that's called into question at this point in time. You're going to need to deal with radiation, mucositis, inflammation. Again, a lot of that's just going to be avoiding irritants like alcohol and tobacco, trying to stay hydrated using neutral or alkaline water. If they develop candidiasis, nystatin, I would tell you that I've had good success using the Carifree treatment rinse for patients that have candidiasis, where I was unsuccessful with nystatin. I'm just throwing that out there as a off-label anecdotal experience that I've had to share with you. Post-restoration, after they've had the radiation treatment, you may have then be able to do more restorative care for them, and you may even take out, try and save and then maybe extract teeth, down the road. And I, as luck would have it, my new patient, one of my new patients yesterday, presented to me. He just had a large malignant tumor removed on the side of his neck just below his ear. He's about to go into head and neck radiation therapy, but first he's having a malignant tumor removed from one of his whole kidney is being taken out. The oncologist sent them to me to try and come up with a plan, and he has an upper denture and he has periodontally, pretty severe periodontally involved mandibular teeth. In our treatment plan, based on all the scientific evidence at this point in time, he's going to lose those teeth, but we're not going to lose them for at least a year post-radiation therapy if I can help it. So we're cleaning everything up so that he can go in and have the surgery on the kidney. But I had, having just read last week that, the Australian paper, being able to share that level of science with he and his wife gave them a tremendous amount of, I think, confidence going into this procedure, knowing that we know what we're going to, we know what the scientific evidence says, we know what we should do, and here's our plan. And, it just gave them, I think, a tremendous amount of trust and hope and confidence going into that. So he's got quite a road ahead of him, but, and my next step is to, speak with the oncologist later this week and find out exactly which teeth are going to be in line with the radiation beam, and make sure that, we've got the right treatment plan for them. But that's, you're going to see these patients, I've got a number of these in my practice. I thought this was interesting. One of the treatments for dry mouth is acupuncture and also electrostimulation. And in a study they found that the acupuncture, there was a low quality level of evidence that acupuncture is no different from the placebo acupuncture, so it really didn't show that it helped at all. And the electrostimulation, again, didn't seem to provide any real evidence of support in terms of treating dry mouth. And this was a systematic review from the Cochrane database. So, I thought it was interesting. I thought, you're going to get these kind of questions from patients. Is acupuncture, can that help me? Electrostimulation, they get all of this information from a variety of sources. I think it's the more that we know, the better. For that Sjogren syndrome patient, when we talk about treatment, I want you to take all of the xerostomia measures we talked about earlier, and that is, number one, fluoride varnish every 3 months. A 5,000 part per million fluoride gel. Hopefully you're using xylitol and helping them stay hydrated, and they're using water that is alkaline or neutral to alkaline. When you're talking about the Sjogren's patient, what I want to add to that is there's a benefit for them to choose xylitol gum. It stimulates salivary flow, and we know that from the Bader study that 5 xylitol exposures a day reduced those root surface lesions by 40%. Most of my Sjogren's patients, I put in a tray, make them an Essex-type retainer tray, upper and lower, and I have them put just a small amount of the 5,000 part per million fluoride gel, ideally all night while they sleep. And I've been able to manage patients and keep them decay-free for years with that regimen. They can look at get them to wear it as much as they can. Maybe they can't wear it at night. If they can wear it for 30 minutes at minimum, but at least if they can wear it the more hours during the day, the better. Because we're just trying to replace the pH of the Carifree gel. The CTX4 gel 5000 has a pH of 9.0, So we're just trying to get that, replace the effects of the beneficial effects of the saliva, get the fluoride in there, the nanoparticle hydroxyapatite, replace the things that are missing because of the saliva is gone. Now you can look at artificial saliva substitutes. There are some on the market that are available. I tried some of those years ago. I found that patients didn't tolerate them very well. They have a really strange consistency, most of them. Some of them are made from bovine saliva. I mean, it's actually bottled cow saliva. I couldn't get past the icky factor on that. I tried them all in my own mouth, and I wanted to know as I was, trying to recommend these things to patients. So maybe that was just me, and I don't have a dry mouth, and maybe I would use them. But anyway, I want you to know those are available. And then you also have pilocarpine, which we know stimulates salivary flow. Pilocarpine, one of the common drug names, brand drug names is Salagen. For Sjogren syndrome, the recommended dose is 5 milligrams 3 to 4 times a day. The maximum effect normally occurs in about an hour, but it may occur later if they take it with food. But typically occurs in about an hour. It lasts about 3 to 5 hours. Side effects, a lot of patients can't take this. Side effects are sweating, profuse sweating, diarrhea, and bronchospasm. So, and then you've got other drug interactions. And I would tell you that go to your drug handbook, guide handbook. There's probably 40 or 50 drugs. There's a long list of them that should not be used in conjunction with pilocarpine for patients. So I've had a couple of patients that they use them from time to time. One of my Sjogren's patients that found it really beneficial. I had a couple that literally couldn't get past the profuse sweating that they experienced. I didn't see anybody with bronchospasm. I did have patients report diarrhea, so it's kind of like it's a little hit and miss, but you need to be aware of the fact that those are some of the side effects, and there are other drugs that you can't mix it with. So that is an option, however, for patients, but I've tended to manage most patients really well just using the protocol that I gave you, in addition to having them in a tray with a neutral or alkaline 5,000 parts per million sodium fluoride, for up to 8 hours a day. So again, this is available, and I know that I don't have the manufacturer. I had the data, but I think it was Brian Novi that shared with me a lollipop that had pilocarpine, and the patient could put it in their mouth for 15 or 20 seconds and suck on it, and then it increased the salivary flow, for a short period of time. So that's another option. But again, most of the patients I've managed is just with varnish gels and trays if we need it, and then make sure they're staying hydrated. So let's look at some patient examples. I just want to share with you just some short histories on patients so you kind of get a feel for, what does this look like. This is a patient that you've seen probably a number of times. I like to use this patient. She's a great example. She has medication-induced xerostomia. I actually looked at her chart today because I always say she's been decay-free for, X number of years. And I first saw her in 2006. She was developing 1 to 2 cavities per year to that point in time. We got her decay-free, and since 2006, that's 8 years. She had 1 cavity, actual new cavity, in 2010 so that's the only cavity she's had in the last 8 years. She's been decay-free for 4 years. And primarily we're talking about fluoride varnish 4 times a year. She uses the Carifree CTX gel, CTX4 gel 5000 instead of toothpaste. She has great home care. She has an effective diet. And she's very aware of the fact of what she puts in her mouth in terms of water. So we're able to manage and keep her decay-free just doing that. But so those are, here's a patient I didn't need to put on an antimicrobial agent. Here's a patient I didn't need to counsel on her home care. Her home care was superb. I mean, this patient brushes and flosses. So it's always nice to have. It's always nice to have one of those in your practice. Somebody that you can have a success story on. But but she's one that I like to use. She's kind of my prototypical medication-induced xerostomia patient. Sjogren's patient, this was a patient that, like I said, I've treated a number of these patients over the years. This patient was referred to me by another dentist. I put her on the fluoride varnish. She has been decay-free 4 years. We established a protocol for her again that was involved the fluoride varnish every 3 months, a 5,000 part per million gel. She used the CTX4 Gel 5000 in a tray at night, so I made both upper and lower trays for her, and we managed her. She's been decay-free. I first saw her in 2010. So she's doing extremely well. I've referred her back to her original referring dentist. So we believe that we have that under control and have her in a management position, certainly from a decay standpoint, that she's stable and knows how to, to stay and remain healthy. Head and neck radiation. This is a patient of mine. Again, this is a patient. I looked at his chart again today as well. He's been decay-free for 4 years. He hasn't had a lesion since 2010. We have maintained the health in his mouth. Again, the same protocol. Fluoride varnish every 3 months, 5,000 parts per million fluoride gel as a dentifrice, and then he's using the CTX gel 4, CTX4 gel 5000. That's a mouthful, in a tray every night. And so he's doing very well. He has actually had oral cancer twice in a 10-year period of time, about 10 years apart. He's had head and neck radiation twice. And so here's a guy that has very little saliva. And let me tell you this, too. There's salivary output will recover, and it will come back. But depending upon which salivary glands are involved or in line with the beam of the radiation, and they're so much better today about targeting and using radiation head and neck therapy than they were 30 years ago, when a patient like this, he would not have teeth today. If he had head and neck radiation 10 years ago, he literally wouldn't have teeth today. And now he's been through 2 separate bouts of it about 10 years apart, and I would tell you that his salivary function is somewhere around 15% of normal, so it's extremely low. He has an extremely dry mouth. This is a patient that carries a bottle of water with him at all times. I mean, it's in his hand. But again, we've kept been able to maintain his health. His last lesion was 4 years ago, and his wife happened to be in today. He's doing very, very well. His salivary input got down to almost nothing, and it's come back to about 15%. It takes about a year. After about 1 year post-radiation therapy, that's about where you see what you got is what you're going to get, and it just doesn't improve much from there. So, but patients like these can be managed effectively, and they can have their teeth. So that's there's an example. So tonight I kind of tried to cover just kind of the highlights of some of the science behind what we understand that contributes to dry mouth, and give you kind of an idea of the protocol, how to manage these patients. It's not really complicated. It's just taking our normal protocols for the high-risk patient, and then just adding and tweaking it, just adding a couple things like the xylitol gum for the patient that's on Sjogren syndrome, or maybe the trays with the gel for a Sjogren's patient or a person that has head and neck radiation. Just making sure that we're really clear about the hydration, making sure that they're using water that's neutral. So that kind of concludes tonight. I hope that I have shared with you information that you found useful and that you can apply to help manage your own patients that struggle with dry mouth. When I started into this, put this webinar together, started putting it together last month, this is a huge topic. I mean, we could literally spend several webinars on each one of these topics individually. So I kind of tried to give you the highlight and cover as much as I could, but also target the material so that I hope you found it clinically applicable. So that concludes. The question I've got is, are you ready? And certainly, if this is the first time you've joined us for a webinar, we have our breakthrough box has product samples that you can try, and has the book that Bob and I wrote called Balance. You can contact, and we're available also for webinars for your team about camera as well. So we've got the most experienced camera trainers in the world on this team. So if there's any way that we can be a resource to you and help you in any way, please let us know. Cody, I'm sure that we have a bunch of questions from tonight.
We do. We have quite a few. Thank you. We're running a little short on time, so we'll get through some of these. I think you obviously covered a lot of the information, but I think it's worthwhile going over them a little bit more.
Okay.
So the first one is, what is the likelihood of patients reporting dry mouth on the CRA form? And then kind of a second part to that was, or how can we rely on them being able to report it correctly?
That's whoever asked that, that's a really good question. Kudos to you for asking that. I mean, when you look at the data, you have, the one report, the study that was published in JADA in 2011, where only 7% of the patients self-reported dry mouth. We have our own data where 27% of the patients reported dry mouth. And then we got the data that was just published in the study where 60% of the patients reported dry mouth and dry mouth symptoms. And so how can we rely on, or what's the likelihood, I think you said, Cody, of patients, accurately reporting the self-mouth or dry mouth, self-reporting dry mouth?
Yes.
I think it's pretty good. My experience in my practice has been pretty good. Most of the patients that have dry mouth have already self-reported it to me. Once in a while, though, I mean, I'll have a patient, something about, and then I'll ask them, and actually when I ask them, they'll come back and say, oh, yeah, my mouth is kind of dry. One particular lady comes to mind that, it finally came down to she was suddenly started developing cavities after being decay-free for a number of years, and it came down to she was taking new medications, and somehow I kept asking her about medications, and she kept denying it, and she wasn't thinking about these prescription medications that she was taking as actually being prescription medications. And when I asked her if she, had a dry mouth, suddenly it kind of like connected for her, and then we kind of got to the bottom of that. She's actually been decay-free now for almost a year and a half. But I think that we can, the way that it's asked on the Caries Risk Assessment form, I think is important. A lot of forms don't ask them to self-report it, and then it's really up to the hygienist or the assistant or the doctor to, in an interview style, kind of ask the patient the question. But I think if they feel they have dry mouth, they probably are experiencing some dry mouth symptoms. So at that point in time, if you want to, you can look for, there are a lot of different little tests, that topic for another webinar, but just pulling back the lower lip and looking and waiting for about 30 seconds and seeing if droplets of saliva form on the inside of the lower lip, or you could actually measure the stimulated, have them chew on the wax and spit in the cup and measure the stimulated flow. But typically, if it's not like you have to measure that. It's like I have to pry the cheek. The inside of the cheek is stuck to the teeth because they don't have any saliva. So those are the kind of patients. They're pretty good at reporting that. But certainly, I think if you have any question in your mind, if you see signs of what you think look like dry mouth, as a clinician, I think it's appropriate to certainly investigate and ask the patient that question. And one of the things that would lead you into it is certainly if they list that they're taking any medications. If they're taking prescription medications every day, the first thing I think is dry mouth, because I think over 3,000 medications now list dry mouth as a side effect of the drug. So that it's most of what we see is medication induced, I think.
Okay. And another great question is, would it be likely a patient could have dry mouth even if they're taking medications that do not list dry mouth as a side effect? And maybe to add to that, maybe if they're taking multiple medications that did not list that, and those would interact?
Cody, that's another really good question. And I would tell you, based on my own experience, there aren't many medications that don't contribute to dry mouth. So I would say it's not very likely that a patient, if they're taking medications, it's likely they're going to have a dry mouth. And the more medications that they take, the more likely it is that they're going to have a dry mouth as well. So, and typically that all tends to be, in a broad sense, that all tends to be age-related as well. So, what I see in my senior patients is the older they get, it seems like the more medications that they're taking. Younger people aren't taking medications, or they're not taking as many. So as they go through that, through life, it seems like they end up taking medications or start taking even more medications. And at the same point in time, their body, through the aging process, is also starting to slow down the normally slow down the amount of saliva that's being produced. So is it a medication or age-related phenomena? I don't know the answer to that question for that specific patient. I'm not sure there's a way for us to absolutely ascertain it. But if they have a dry mouth, regardless if it's from age-related or medications, certainly we have a protocol, and I would encourage you to just, implement the protocol, and I think that you'll have really good success with that. Great question, Cody, by the way.
Good. And so the last one, though, I think we'll have time for tonight, and this is another two-part question as well. What are your recommendations for patients going through head and neck radiation therapy, maybe in the future or currently, and then as well as recommendations for patients that have gone through radiation therapy in the past?
Okay. Well, that was literally, I think, the two head and neck patients that I talked about in the program tonight. The patients that are going through head and neck radiation therapy or they're about to go through it, certainly I think the protocol is to get all the teeth cleaned as well as you can, get the disease out of the mouth as much as you can, restore the teeth that are restorable. If you have teeth that absolutely have to be extracted, extract them as soon as you can. You need at least 10 days to 21 days, ideally, prior to the start of the radiation treatment. That's in the scientific evidence. And then maintain the teeth just as, even if they're periodontally involved, just hang on to them. Try and keep the gums as clean as you can. Put them on, the fluoride varnish. Get them on the 5,000 part per million fluoride. Do what you can to help maintain those teeth as long as you can, knowing that, like the patient that I saw yesterday, I told he and his wife, a year from now, we're probably going to take out most of your teeth because they're not teeth. If you weren't going through radiation treatment, right now I would say let's talk about a lower denture because these teeth aren't really that savable. But I want to save them, get them through the radiation treatment, and then extract them post-radiation, like down a year or so. The scientific evidence indicates patients tolerate that better, or there may be reduced risk for osteoradionecrosis rather than taking him out up front. Particularly, he's about to go into radiation therapy in the next couple of weeks. For the patients that have been through it in the past, like the patient I presented tonight, I mean, when I first saw him, let's say in 2006, so he had been through head and neck radiation therapy a couple of years prior, and he was starting to develop a lot of decay. The amount of saliva that he had at the time was all that he was going to have. So we kind of tailored our therapy or strategies to what he had at the time for saliva. When he went through the head and neck radiation therapy again a couple of years ago, I mean, his salivary output got down to near zero, and so we had to refine that and literally put him in trays. I wanted him in trays 20 hours a day, but I was able to get the trays 8 hours a day, and that worked. And then it's literally, he's a patient that, these kind of patients are going to need to have a bottle of water in their hand pretty much throughout the day because they're going to have almost no saliva. So for the patient who's been through radiation in the past, depending on how long it's been, what their decay rate or their caries experience looks like, you just need to tailor your strategies to make it appropriate for the patient. And that's about the best I can tell you. If I would tell anybody that's on tonight, if you have a patient that you have questions about specifically, please contact me. Let me share with you whatever my thoughts or ideas are. If you have a question about a patient, I'm happy to share any information I have if it can benefit you and your patient. So again, think of me as a resource. Think of Carifree as a resource as well.
Great.
Thank you, Cody.
Yeah, thank you very much. I think that wraps up all the time that we have tonight. That was certainly a lot of really great information. Thanks, everyone, for all of your great questions. Again, any that weren't answered tonight by Dr. Kutsch, we will get to them via email in the next few days. And so you'll get those, look for those. We really appreciate your time. Thank you for participating in the webinar. We'll also send out an email here in the next day with a recording for anyone that wants to share the webinar with staff or colleagues. And feel free to contact us with any questions that you have. Again, also, if anyone is interested in implementing Canberra, reach out to us. We can certainly offer one-on-one webinars for you, your staff, the team to answer questions and help you guys get started. So thanks again, everybody, and have a great night.
Yep, thank you everybody for spending your time with me. I hope that you found this information helpful. Until next time, from downtown Albany, Oregon, good night.
Night.